So I'm going to be talking about pregnancy and substance use disorder. And I work for El Centro Family Health in Española, and I really love taking care of pregnant women with substance use disorder and their babies. And when I first started doing this, golly, must be 12, 13 years ago, and I would tell people that I love taking care of pregnant women who are using drugs, I would get a response approximately, equivalent to what I'd said if I announced I liked clubbing baby seals, because people just couldn't believe I wanted to take care of this group. But it is truly such a rewarding thing to do. We all, when we applied to medical school or nursing school or counseling school or whatever your degree is, what we all said was that we wanted to do this so that we could help people. And if you want to help people, this is where we're going to help people more than anything else that we can do in medicine. You can just make such a difference with this group. So I have no relevant disclosures. And we're going to be talking about pregnancy and the postpartum period. I'm going to be talking about the effects of substance use during pregnancy on the newborn, and I will talk about neonatal opioid withdrawal. Oops. And learning objectives: understand the effect of alcohol and illicit drugs on pregnancy, discuss the rationale behind use of medication treatment for opioid use disorder during pregnancy, realize the importance of the postpartum period, and be able to discuss neonatal abstinence syndrome or neonatal opioid withdrawal. They're pretty much the same thing, and Child Protective Services involvement with the patient. And I'm just going to briefly go through some OB terms for people who are not regularly doing obstetric care, because I will be just tossing these out throughout the presentation. G is gravida, which is the total number of pregnancies. P is para, which is the total number of deliveries. So if you're a G2, P2, you've been pregnant twice and delivered twice. If you're a G3, P2, it can mean one of two things. It can mean either that you've been pregnant 3 times and had 2 deliveries and you're currently pregnant, or you've been pregnant 3 times, had 2 deliveries, and either a miscarriage or an abortion. XX weeks is the weeks since the last menstrual period or the weeks since conception plus 2. So full term is generally 37 to 41 weeks gestation. IUGR is intrauterine growth restriction, which is a baby who on ultrasound is weighing less than the 10th percentile. SGA is the same baby, but after they've been born. Their newborn baby weighs less than the 10th percentile for gestational age. Preterm labor is labor at less than 37 weeks, and preterm delivery is delivery at less than 37 weeks. And placental abruption is when the placenta pulls away from the wall of the uterus. If you get small abruptions, the placenta is how the baby gets nutrition. So if you have part of the placenta not attached, that means the baby's not going to get nutrition from that part of the placenta, so it can cause the baby to be small. It can also cause preterm labor because the blood is very irritating. Large abruptions can actually be fatal for both mother and baby. And the reason I bring these up is these are common complications of substance use disorder during pregnancy. And since it's echo, I'm of course going to start with a case. 33-year-old G4P3, she'd been stable on buprenorphine and naloxone for 4 years. She presented to her buprenorphine provider for routine appointment and was discovered to be pregnant. Her buprenorphine provider was not comfortable taking care of pregnant patients, and because of this, did not give her a script.
That's good. Good.
Not surprisingly, she relapsed to heroin. She presented to our clinic at 25 weeks gestation. She wanted to get back on the buprenorphine. Because of transportation difficulties, we were not able to get her restarted, and she ended up delivering a premature infant at 31 weeks. She almost delivered in the helicopter. It was kind of scary. She ended up restarting the buprenorphine postpartum. Both she and the baby did well, and I actually saw her last week. Baby is about to start kindergarten. So next this is how we want to do it. This is sort of the ideal situation. 22-year-old G1P0 presented at 9 weeks gestation. At that time, she was actively using heroin. She desperately wanted to keep both the pregnancy and to keep custody of the baby after the baby was born. She was started on buprenorphine maintenance. She did great. No relapses. Child had no signs of neonatal opioid withdrawal syndrome at birth, currently 7 years old and doing well. So the use of alcohol, tobacco, and drugs during pregnancy is actually the leading preventable cause of mental, physical, and psychological impairments in children. Between 1998 to 2011, there was actually a 127% increase in opioid-dependent pregnant women presenting for delivery. I have not seen any stats on this for the last 12 years. I am pretty sure it has continued to go up, but I just have not seen these stats. And opioid-dependent pregnant women have an unintended pregnancy rate of 86%. So if you are treating patients who can get pregnant, you want to provide contraception or refer for contraception if you're not comfortable doing that. But please make sure that these patients get on contraception if they do not want to get pregnant. If you're seeing a pregnant patient, we do recommend screening all pregnant patients for substance use. And the best screen is what we call the 4 Ps. First P is parents. Did either of their parents ever have a problem with alcohol or drugs? P is partner. Does their partner have a problem with alcohol or drugs? Third P is past. Have you ever had a problem with alcohol or drugs in the past? And fourth P is past 30 days. In the past month, have they drunk any alcohol or used any substances? Obviously, a positive answer to any of these does not mean that they are going to definitely have a substance use disorder, but it does mean you need to ask a lot more questions and just sort of be aware that it may be an issue. And you don't have to use this one. If you have other questions that you think work better for you, yes, go ahead and use those, but just make sure you're screening somehow. And what are the medical implications of substance use disorder with pregnancy? And then what is the significance of pregnancy for any substance use disorder? And this is just a phone survey where they called women and said, are you pregnant and are you using illicit drugs? And what they found was that during pregnancy, this was not people who were involved in a treatment program. I mean, some of them may have been, but this is just people who were pregnant. What they found, over half of the women between age 15 to 25 had stopped using illicit drugs, and almost 3/4 of the women between 26 and 44 had stopped. This was true across all race groups, that there was a substantial decrease in their use of illicit drugs when they were pregnant. However, the reason we don't recommend that patients who can get pregnant with a substance use disorder go out and get pregnant is because of what happens postpartum. And if you look, so in all of these graphs, the bar on the left is not pregnant and not having given birth in the last year. The bar in the middle is currently pregnant, and the bar on the right is not pregnant but gave birth within the last year. And what we find, it does not go quite back up to baseline, but probably 80 to 90% of these patients relapse during that first year postpartum. So if we can identify these people while they are pregnant, then we can get them into treatment. We can get them support. We can refer them to peer support. We can really help them so that they do not go back to using drugs or alcohol postpartum. So the drug with the most teratogenic potential is alcohol. Teratogenic means that it can cause birth defects. And we tend to really focus on illicit drugs, especially opioids have been very well covered in the news recently, but alcohol is still by far and away the most dangerous drug during pregnancy. And sort of the worst case scenario with alcohol is what we call fetal alcohol syndrome. And this involves 3 things: a small baby, a smaller abnormal brain, and some minor facial anomalies. And the baby has to be less than the 10th percentile, either on ultrasound or after the baby's born. The brain needs to be less than the 10th percentile, or it needs to have developed abnormally somehow. And the baby, these babies, that little notch that you have under your nose, that tends to be smooth and not there with babies with fetal alcohol syndrome. Their upper lip may be really thin. They may have short palpebral fissures. And here's sort of a picture of it. I gotta say, I see a lot of babies that I'm worried about this, and I find this incredibly difficult to diagnose. So I think more important than being able to diagnose it yourself, if it's not something you're doing regularly, is we want to identify the people who are using alcohol during pregnancy and get those babies referred to a developmental clinic where they're very comfortable making this diagnosis. You can kind of look and be concerned that, oh, that upper lip is really smooth and the colored part is really small. But if you're not doing it regularly, I think it's hard to diagnose, and I do recommend that you get a specialist involved. And before I move on, so fetal alcohol syndrome is sort of the worst manifestation of this, And that's about 1 in 1,000 babies. Much more common is what we call fetal alcohol effects. And these are babies who are either small or have abnormal brain development or maybe some abnormal facial features, but they don't have all three. And what's really significant, they think it may be anywhere from 2 to 5% who actually just have some problems with executive functioning. This is really common in babies with some alcohol exposure who don't actually have the full fetal alcohol syndrome. And somebody pointed out these are the ones who can't seem to remember to come in for appointments in the office. They have trouble keeping a job because they don't know they need to show up on time. They may not be able to pay their bills. They forget to pay rent. Those sort of things that you need to do to be an adult may be really hard for these babies when they grow up, even if they don't necessarily have full-fledged fetal alcohol syndrome. Tobacco is also really significant, and this is another one that we often don't think as much about. Neonates born to mothers who smoke weigh an average of 200 grams less than neonates born to mothers who don't smoke. And roughly a fifth of all sudden unexpected infant deaths or SIDS or crib death can be directly attributed to maternal smoking during pregnancy. So this is something we really want to talk about because this is devastating to lose a baby to this. And if we can do anything to decrease it, then we want to do that. Cannabis is one that's really hard. When I first started talking on this about 10 years ago, I pretty much ignored this and said, oh, cannabis is fine. But as we do more study, we're really becoming convinced that there is probably some risk to cannabis during pregnancy. It's really difficult to get definitive answers on this. The first is that pregnant patients who are using cannabis are often using other substances, especially alcohol and tobacco. And it's hard to tell whether the adverse effects are due to the alcohol, the tobacco, the cannabis, or are the three combining to make things worse. Another problem is that psychosocial variables such as income, age, and education can vary. There may be pre-existing conditions such as ADHD or anxiety. So it's very common for people to self-medicate with cannabis for these conditions. And then when the baby ends up having these conditions when they are in their teens, is it because the mother used cannabis or because of a genetic predisposition? Another problem is that many studies were done before the level of THC was as high as it is now. Cannabis use is super common. The prevalence of cannabis use is somewhere between 2 to 5% in pregnancy, and it increased from 2.37% in 2002 to 3.85% in 2014. I have seen definite there are studies that show that it increases in states that legalize it. There was one study where 2.6% of patients reported that they had used cannabis during pregnancy, but when they checked the umbilical blood, about 22% or 1 in 5 had actually used during pregnancy. The most common reasons to use cannabis in pregnancy are morning sickness and to manage anxiety or depression. However, cannabis can lead to cannabis hyperemesis syndrome. And I haven't seen any studies on this, but it seems to me that a lot of the patients I've had with morning sickness then go on to, who are using cannabis for this, then go on to develop cannabinoid hyperemesis syndrome. And that is so much worse than morning sickness. And these patients are often in the hospital every week throughout their pregnancy, dehydrated and really, really sick. So I personally feel like the possibility of developing cannabinoid hyperemesis syndrome during pregnancy is enough that I tell people not to do it. The data is mixed on the actual outcome. It
manager's information.
as far as birth weight, birth defects, other outcomes may be due to cannabis, may be due to alcohol or tobacco, may be due to the combination. We're not really sure. It does seem likely that there's going to be a pattern of neurobehavioral effects, hyperactivity and sleep problems in toddlers, ADHD in preteens, emotional dysregulation in adolescents. And actually that last one is generally where I can talk people into considering quitting because no one wants an adolescent who is emotionally dysregulated. So what we need to tell our patients. Pregnant patients complain that they are hearing mixed messages from healthcare providers. They do state they want more research on the safety and effect of cannabis with pregnancy. So what I tell patients, there's no recognized safe amount of marijuana with pregnancy. It has not been definitively found to be dangerous. It most definitely has not been found to be safe. And I think we need to be giving our patients that message. It is also likely much more dangerous if it's combined with tobacco and alcohol. There's very likely a risk of long-term cognitive effects with use of cannabis during pregnancy. And it may help with the symptoms of morning sickness. It can also lead to cannabinoid hyperemesis syndrome, which is way worse, and there are much better treatments. Stimulant use in pregnancy, both meth and cocaine are associated with preterm delivery or early babies, low birth weight babies, which are just babies who are small, either because they were born early or because they were small for gestational age. And it also can cause babies who are small for gestational age. Opioid use disorder. Both opioid use and withdrawal have a fetal effect. However, during the pregnancy, the withdrawal effects are actually usually considered much more serious. This is why when you get someone coming into your office who's pregnant and using fentanyl, we don't just tell them you need to stop, because the withdrawal during pregnancy can actually be pretty dangerous. Withdrawal causes a hyperadrenergic state, which is adrenaline or epinephrine, and then the hormones that are similar called noradrenaline or norepinephrine. The most significant part of the release of this for pregnancy is it causes constriction of the blood vessels. It causes constriction of all the blood vessels in the body, but in particular, it causes constriction of the blood vessels in the placenta. And when you get the blood vessels in the placenta clamping down, you're not getting nutrition going to the baby. It can set off preterm labor. It can cause a placental abruption. This clamping down of the blood vessels in the placenta, unfortunately, is made worse by both cocaine and methamphetamine. And for my patients, it is often very common that when they cannot get fentanyl or other opioids, they'll use a little bit of cocaine or methamphetamine to take the edge off. And unfortunately, during pregnancy, that is going to make all the problems of opioid withdrawal much worse. The biggest direct effect of opioid use is neonatal opioid withdrawal syndrome at birth. All right. Before I move on, any questions about the medical effects of drug use on pregnancy?
So there was one question in chat from Lisa Fearman saying your slide said a high percentage of SIDS deaths is attributed to maternal smoking. Did you mean associated, or is there a known causal effect?
I don't think we've definitively proved a causal effect, although it makes sense because nicotine, similarly to cocaine and meth, causes the blood vessels in the placenta to spasm down. So these babies are going to come out a little less healthy. And there's some concern that because they tend to be a little bit stimulating, the babies are going to be sort of less active, sort of less responsive when they fall asleep. But I don't think they've definitively proved causation. They think it is likely, but I don't remember seeing anything that's definitively proved causation. Any other questions?
That was the only one in chat. If someone has a question, please feel free to unmute.
All right. Next is a 28-year-old G5P4 on methadone maintenance. She disappeared from care at about 20 weeks, returned at 38 weeks in labor. I found out many years later that she had actually found a family member who had died of an overdose when she disappeared, and just ended up relapsing. She told me she'd been at a methadone clinic in another community. Her urine was negative for methadone, positive for opiates. Baby went into horrible withdrawal at birth. Child Protective Services ended up becoming involved. They took custody of the child. The mother actually ended up being arrested when she and her cousin, who was the foster mother, got into a physical fight on the OB floor. So what are the psychosocial implications of substance use disorder with pregnancy? Co-occurring disorders are very common. Both substance use disorder and depression cause very poor self-care. And domestic violence is the second leading cause of trauma-related death in pregnancy. All three of these tend to occur together. So if you have any one of the three, you really want to do extra screening to see if either of the other two are present. In addition, most mothers have a really high motivation to change during pregnancy. There can be legal implications around custody of the baby and older children. Again, substance-using pregnant women have very poor self-care behaviors. If they continue to use drugs, they're not going to take very good care of themselves during the pregnancy. They're not going to exercise. They may not be coming in for prenatal care. They may not be eating healthy. All of the things that we want everybody to be doing, but especially pregnant patients, are going to be less likely if they're using substances. There may be a history of childhood sexual abuse or physical abuse, and this can often have implications for parenting. And then women who use drugs often start using because their male partners use drugs. If they are still with that partner, it can be really difficult for them to quit unless he quits as well. Oh, the other thing about the history of childhood sexual abuse, it can really come out during labor because patients end up with a lot of pelvic exams during labor, and they may have to be undressed for a lot of it in front of people. So we need to be aware that that can be an issue. All right. 25-year-old G2P1 presented at 26 weeks stating, "I'm addicted to fentanyl." She is scared that she will lose the baby to Child Protective Services or have medical complications. She wants to get into treatment. Is medication therapy an option for her? Which is better, buprenorphine or methadone? What about weaning off the fentanyl and using abstinence-based therapy? And does she need any special care for her pregnancy? So first thing on these patients, it's really important that we get them in for prenatal care. Often we get so focused on the substance use disorder and we want them to quit using fentanyl or we want them to quit using the methamphetamine that the prenatal care becomes sort of secondary. But this is really, really important that they get prenatal care. There was a study in the Journal of Perinatology, and it was found that women with illicit drug use and no prenatal care had the highest risk for prematurity, low birth weight babies, and small for gestational age infants. As the prenatal care increased, even if they did not quit their drug use at all, their risk for prematurity, low birth weight, and small for gestational age babies dropped. This is because the stuff we do during prenatal care, monitoring for infection, making sure that they're not anemic, getting them on prenatal vitamins, following ultrasounds to make sure that the baby is growing well. This all actually really makes a huge difference. And it especially makes a difference for any pregnancy that's high risk and patients with substance use disorder are high risk. Unfortunately, though, patients will often delay or not get prenatal care because of the stigma and the fear of consequences, including being reported to Child Protective Services. So we really need to make sure that our offices are safe places for these patients, because if they're scared to come in, we've missed a great opportunity to intervene and help both them and their baby. Abstinence-based therapy is not recommended during pregnancy for anyone who is actively using opioids. To phrase it a different way, medication therapy for opioid use disorder is standard of care for pregnancy. If you remember nothing else from this talk, I have 3 things I want you to remember. This is number 1. Medication therapy is standard of care. Benefits of medication for opioid use disorder. There was a recent study of close to 11,000 pregnant persons with opioid use disorder on Medicaid, total of 13,320 pregnancies, and they found the following benefits for medication for opioid use disorder, either methadone or buprenorphine. They're both great. Decreased rate of overdose, decreased preterm birth, decreased low birth weight. All of the above outcomes improved the longer that you had them on medication for opioid use disorder during pregnancy. But of note, 42% of patients did not have a pharmacy fill for medication for opioid use disorder during pregnancy. This is standard of care, and almost half of these patients were not getting it. Medication therapy can be done with either methadone or buprenorphine. Both of them are going to really improve pregnancy outcome and improve opioid use disorder down the road. Methadone has been used for longer. Most providers prefer to start with buprenorphine if available, and the reason for that is twofold. The first is that there was a study in 2010 in the New England Journal that showed significantly less neonatal opioid withdrawal syndrome in the buprenorphine group than the methadone group. Babies exposed to buprenorphine required 89% less morphine. They had a 43% shorter hospital stay and a shorter duration of treatment than babies who were exposed to methadone. That said, I think we overstate neonatal opioid withdrawal and understate the importance of making sure that the pregnant person is not using opioids and getting good treatment. So while I prefer to start with buprenorphine in part because of this, I do think if the patient needs to go on methadone, we put them on methadone. It is very, very important that we get their opioid use disorder treated. The other reason I do start, though, with the buprenorphine is that if there are going to be some patients who respond well to methadone and not to buprenorphine, there are also going to be some patients who respond well to buprenorphine, but not to methadone. If I start buprenorphine in a pregnant patient, it is very easy to transition them to methadone if the buprenorphine does not work for them. However, if we start methadone first, it is very, very difficult to transition them to buprenorphine while pregnant. So I think I prefer to start with buprenorphine because then if it doesn't work in 2 to 4 weeks, I still have the option to switch them to methadone, whereas unfortunately, I don't have that option the other way around. Access to buprenorphine while pregnant. There was a 2020 study of obstetricians that showed only 1/3 of obstetricians always recommend medication for opioid use disorder. 1/4 never recommend it. I find this astonishing. This is standard of care, and nonetheless, 1/4 of obstetricians are not recommending it. I cannot think of another condition where we would allow that large a percentage of people not to recommend standard of care. And then the other problem is that it's going to be harder for a pregnant patient to find someone to give them medication for opioid use disorder. A study where they called methadone providers found that 97% were accepting new patients, but only 91% would accept them if they were pregnant. And it was far worse for buprenorphine. 83% of buprenorphine providers were accepting new patients, but only 51% would accept them if they were pregnant. So if you are prescribing buprenorphine, please consider taking pregnant patients. It is really very rewarding. It is really not any more complicated than taking care of a non-pregnant patient, and there are such great benefits to taking care of this group. Another thing is for both buprenorphine and methadone, we do really want to split the dose during pregnancy. A recent SAMHSA alert talked about this. Pregnant women tend to metabolize both of these medications much more rapidly. And so as a result, even though methadone is normally dosed once a day and buprenorphine normally once a day, you want to for sure be dosing it twice a day and possibly more frequently during pregnancy. And I do just want to mention real quick morning sickness and methadone. Both ondansetron and methadone can cause QT prolongation, which is an abnormality of the EKG. So you want to be extremely cautious if you have a patient on methadone with morning sickness, because if you use ondansetron, you could potentially put them into cardiac arrest. So you want to use other treatments first. Lifestyle changes, small frequent meals, avoid fluids with the meals, eat something before they get out of bed, popsicle. Ginger actually has really good evidence for morning sickness. And pyridoxine and doxylamine also have pretty good evidence. And a comment in the chat that most antiemetics prolong the QT, unfortunately, and that is true. So you really need to be cautious treating anybody with nausea who is on methadone. What about medically monitored withdrawal? So there was a recent analysis of 15 studies with almost 2,000 participants. 1,100 went to detoxification. The problem is these studies were really not great studies. There were no randomized controlled studies. They were mostly done in an inpatient or residential setting. So if you're thinking about doing this in the outpatient setting, you really have absolutely no data behind it. There were 3 studies done in jail. And I mean, it was just nothing that you could draw a conclusion from. The detox rates ranged from 9 to 100%, relapse ranged from 0 to 100%. There were 2 maternal deaths from postpartum overdose in one study. The rates of fetal demise and birth weights were similar between the groups, and the rates of neonatal abstinence syndrome rates from 0 to 100%. So there has just not been any study of this. And more importantly to me, and I'll talk a little bit more about this in a moment, no study of medically monitored withdrawal has examined maternal outcomes postpartum. And I think this is one of the most important time periods that we need to be looking at. And no one has ever seen if these patients who were weaned off of opioids during pregnancy, how they do after they deliver. So before I move on, any questions about use of medications during pregnancy? All right. So next case study, 34-year-old G2P1. She'd been on buprenorphine naloxone for heroin use disorder. This was one of my very first buprenorphine patients. She moved away, got pregnant, weaned herself off the buprenorphine. She moved back to Espanola, where I practice. She declined to restart the buprenorphine because, quote, I am not going to ever go back to drugs. She had a great pregnancy, all negative urine drug screens, normal spontaneous vaginal delivery, healthy baby. And she ended up dying of an overdose about 1 year postpartum. It was absolutely devastating. And at the time, I just thought it was, sort of bad luck or something bad that happened. But as I've done more reading, I've realized this is actually really quite common. Studies from Maryland, Tennessee, Colorado, Utah, Ohio, and Massachusetts have found that postpartum overdose is one of the top causes of maternal mortality. It causes anywhere from 15 to 33% of all maternal related mortality. New Mexico actually did this really well done study last year, and they found that 47% of maternal deaths were connected to substance use. So this includes postpartum overdose, postpartum suicide, car accidents, murders, we all know that substance use disorder can contribute to deaths from all of these causes. 42% actually were had a mental health condition contribute, and 19% had a history of intimate partner violence. So again, we want to be looking at these risk factors in pregnant patients. Suicide is also a substantial contributor to postpartum mortality. And the risk factors for postpartum opioid overdose and postpartum suicide really have significant overlap. Again, the three most common: depression, intimate partner violence, and substance use disorder. You'll hear a theme here with this. So we want to screen for depression postpartum. I use the Edinburgh postpartum depression screen. If you have another tool you like better, you're welcome to do that. Even just asking the patient, are you sad? How's your mood been? Things like that. Just whatever you do, you want to screen somehow. Our tendency is we get to end of pregnancy, we have a healthy mom, healthy baby, and we tend to pat ourselves on the back, think our work here is done. But this is such a dangerous time. We really want to make sure that we're paying close attention. And comment from Julie that the postpartum time is quite stressful. Looking for a way to ease stress would be really strong. I think it is so important to realize that. I think there's often this vision that, oh, you have a newborn, you're going to be sort of glowing and happy. And it's often not the case. You've gone 9 months being the center of the universe. Once you give birth, nobody ever looks at you again. Your hormones are wreaking havoc with your emotions. You're sleep deprived. And so it is just a significant risk factor for depression and for relapse. Dr. Pardo-Friedman points out if they have been in treatment or abstaining, their tolerance is also going to be far lower, and they don't know it. So they use old doses that can also lead to overdose. And that is also a really significant contributing factor, is that since patients often do quit during pregnancy, their tolerance will be so much less. And this increased maternal mortality continues for many, many years after delivery. There was a study in 2019 where they looked at mothers in Ontario and England who had a baby with neonatal abstinence syndrome. And what they found was the mortality rate was over 10 times as high as mothers who did not have an affected baby. Roughly 1 in 20 mothers died over the next decade. So 5% of children who had neonatal abstinence syndrome then went on to lose their mother in the first 10 years of life. Interestingly, the top cause of death was not drug overdose. It was unintentional injuries, in particular car accidents. And so one small thing I started doing after I read the study is I ask every single patient on buprenorphine if they are wearing their seatbelt or not. Any patient with substance use disorder in general, are you wearing your seatbelt? And I found about 15% of my patients weren't doing it. I managed to get about half of them wearing their seatbelt. I haven't gotten all of them, but I'm still working on it. There were also high rates of murder. So screening for intimate partner violence, again, is really important. High rates of suicide, screen for depression. Drug-related deaths, in particular overdose. And then what they call unavoidable deaths, which are medical deaths that are not cancer, and presumably includes things like cirrhosis and aspiration pneumonia that people with substance use disorder are more prone to develop. All right, any questions about the postpartum period before I move on to neonatal opioid withdrawal? So, oh, that was the second thing I want you to remember. Remember the postpartum period, screen for relapse, screen for postpartum depression. Make sure we're supporting patients through this time period. All right. This is the third point that I'd really like people to remember. And comment that the Edinburgh scale is the gold standard for depression screening during and after pregnancy. So yes, like I said, that is the one I use. I think it's a great screen. If you have another one you're more comfortable with and feel you're getting good results from it, just make sure you're screening these patients. So neonatal opioid withdrawal syndrome is physical withdrawal from opioids in a newborn. Neonatal opioid withdrawal syndrome does not mean that the baby is addicted to drugs. I think language is really important. I was giving this talk to a community group at one point, and they made this point. And afterwards, there was an 11-year-old there with his mother, and he had been told all of his life that he was an addicted baby. And he went up to his mother and he said, I realized I'm not actually a drug addict. My whole life, everyone has told me I was an addicted baby, so I just assumed I was a drug addict. And now I'm realizing I'm not. And I want to go to college so that I can become a counselor and no one else has to go through what I went through. So language really matters. So this one I think is important enough. I actually make everybody swear an oath. You can either unmute and say it over the microphone, or you can put it in the chat. But do you solemnly swear that you will never refer to a baby with neonatal opioid withdrawal syndrome as an addicted newborn?
I
Yes,
do.
I do.
I do.
Awesome.
I do.
I think this is so important.
I
So
do.
thank you all. All right. Clinical definition of neonatal opioid withdrawal from the AAP. They finally came up with a standard definition in October of 2020, which is really important because a lot of the studies use different definitions. So it was really hard to tell when something was actually improving outcomes. So you need two things for neonatal opioid withdrawal. The first is in utero exposure to opioids, either by itself or with other psychotropic substances. And you can find this a couple different ways. You can ask the mom, were you using opioids during pregnancy? And if she says yes, that's all you need to do. You can also do drug screening on the mother's urine, the baby's umbilical cord, if you have appropriate consent. The clinical signs characteristic of substance withdrawal, and you can have any two of the five. Excessive crying. These babies are very irritable. They cry for almost anything, and they'll cry nonstop, very high-pitched cry. Fragmented sleep. They tend to sleep less than 2 to 3 hours at a time. They have tremors. These babies tend to be very, very shaky. They're very stiff. You pick them up and their whole body moves kind of as a unit. And GI dysfunction. They want to eat all the time, but despite the fact that they just want to suck and eat all the time, they don't feed very well. They don't latch onto either a bottle or breastfeeding very well. They don't tend to tolerate feeds very well. They'll throw up frequently, and they tend to have very loose and watery stools. So you need 2 of the 5 of those symptoms to diagnose neonatal opioid withdrawal syndrome. And we really want to be doing non-pharmacological treatments for these babies. Non-pharmacological treatments includes things like small and frequent feeds, quiet, dim room. You want to speak slowly, and softly, and move, don't be very bustly around these babies. You want to do everything very slowly and deliberately. Swaddling really helps. Keep them skin to skin. And when we've had babies where the mom left the hospital and the babies were still doing withdrawal, the nurses would just put them in a sling and wear them around the unit. Family involvement with rooming in is really important. And studies at Dartmouth and Yale showed far shorter hospital stays and less need for medication when you use non-pharmacological treatment. No bad effects. The study at Yale, up until 2008, all babies at Yale with any opioid exposure, be it heroin, pain pills, methadone, buprenorphine, no matter what it was, at an hour of life, all of these babies went into the NICU, and 100% of them ended up needing medication for opioid withdrawal. Yale started doing all of these non-pharmacological treatments, and they've done an amazing job with it. And what they found was that they went from 100% needing medication down to about 10%. I mean, this is just a huge, huge difference. So really, as much as possible, even if the babies do need medications, we want to be doing the non-pharmacological treatments. And then breastfeeding. All of the cool kids, the Academy of Breastfeeding Medicine, the American Academy of Pediatrics, the American College of OBGYN, the Substance Abuse and Mental Health Services Administration, and the American Society for Addiction Medicine, all of them recommend breastfeeding for women with substance use disorders who are in a treatment program and have had negative drug screens for 2 months prior to delivery. And this includes women on medication for opioid use disorder, methadone or buprenorphine. These patients can breastfeed their babies safely. And so if they have not been in a treatment program, or if they've used more recently than 2 months, then you need to sort of make a more individualized decision, depending on whether or not you think they're likely to participate in treatment, how likely are they to continue using. You don't want anyone breastfeeding if they're actively using, obviously, but it is safe for patients who are on MOUD to breastfeed, and it is safe for patients who have had negative drug screens for 2 months prior to delivery, who were using meth earlier in pregnancy to breastfeed. And then last, I want to talk about child protective services. There was a study in Manitoba that showed that losing custody of a child to child protective services is associated with significantly worse maternal mental health outcomes than experiencing the death of a child. And they did whatever statistical stuff they needed to do to account for the fact that patients who lose child to child protective services often have more mental health problems to begin with. What they found was the risk of depression was almost twice as great for women who had lost a child to child protective services, and the risk of substance use was 8.5 times greater for women who had lost a child to child protective services. And there's 3 things I think we need to get out of this. The first is that patients who have lost a child to child protective services, and I would include fathers in this as well. I haven't seen studies on this, but anecdotally, I'll say that it seems to affect a lot of them this way as well. These patients are often really struggling. They may be, not wanting to admit it to you, but don't shame them. It's very easy to look at them and say, well, what do you expect? You were using cocaine while you were driving and got in a car accident without your baby being in a car seat. Of course, you're going to lose custody. Don't do that. Everybody else in their life is shaming them. They are shaming themselves. We can be a source of compassion for them. The second thing is these patients really need care. They're likely going to have significantly increased risk of depression and substance use disorder. We want to be screening them. We want to be getting them treatment. And the third thing is we should never sort of retrospectively look at a patient who's lost custody of their baby and say, oh, thank God we took the baby away from Penelope. Look, she's living in the back of her car at Walmart and using fentanyl 20 times a day. It may be the other way around. It may be that she would have done okay had she actually kept custody of her baby. But because of the pain of losing that child, she's now got a much worse substance use disorder. And, there are definitely times where patients are not able to take care of their children because of their substance use disorder. But I think it's really important that we do what we can to support these patients so that they can keep custody of their children. Sixto, did you have a question?
Yes, well, it's more like just wanted to share a little bit because now that you were talking about that, when I was in my substance use, I actually passed out at the wheel with my son, right?
Wow.
I had been on a binge, and actually that's the whole reason I seeked out recovery, and I've been clean and sober since, but I know that just like how you're saying, it could have been either way. Like if they would have luckily they didn't take my son away. They called my mom and asked my mom to come and pick up my son, right? But yeah, I mean, that's what made me realize, like I needed help. I mean, so if they would have taken my son, it could have went the other way around. I could have probably went more into my addiction, continued my addiction.
Yeah, and this is the reason it's so important to support people rather than just writing folks off, because you've made such a difference to the community and to so many people by having gotten in recovery. So I think there is a tendency for us just to kind of write people off, but we really want to be supporting people. So
yes, that's what we really do.
All right. So we want to talk about child protective services involvement during pregnancy. There's a tendency to be really hesitant about this because if we bring it up, we're afraid that they're going to, we're going to upset the patients or that they're going to leave and never come back. But I find that almost every patient I've had who's been pregnant with substance use disorder knows about the possibility of Child Protective Services involvement, and they are terrified. And if we talk about it and actually give them information, then we can actually sort of relieve some of their fears because they know what's going to happen. So we want to talk about what will trigger a referral and what will happen if they do get a referral. So, and I have some idea of what's likely to happen. If they're doing fine, but they're going to have a referral because of intermittent cocaine use, then it may be that they'll need a safety monitor. It may just be that they need to commit more to treatment. But talk about things like that. If they're actively using and don't have a place to stay, probably someone will take custody of their baby. So they need to have a plan if they want to maintain custody of how are they going to be able to do this and do it safely. So if there is a referral made, I tell them they need to do 3 things. The first is they need to be honest with Child Protective Services. These are people who are used to trying to hide their substance use, both from themselves and from everyone around them for many years. But if they do that with Child Protective Services, unfortunately, Child Protective Services is not going to be as willing to work with them. So really encourage them to be honest, encourage them to have a plan for substance use disorder treatment, and make sure they have a plan to ensure that the baby is safe. This may be that they're going to go stay in, as in Sixto's case, with one of their mothers. It may be that they're going to have a relative come stay with them, but make sure that there's a plan to keep the baby safe. So take-home messages. Alcohol and tobacco are the most dangerous drugs for the fetus in pregnancy. Medication treatment is recommended for opioid use disorder in pregnancy. The postpartum period and after is a really high-risk time for relapse and death in women with substance use disorder. And use non-medical treatments first for neonatal opioid withdrawal. And that is all I have. What questions do people have?